This conference will now be recorded.
The second thing that I have to do is to open the meeting by saying it's June 5th. This is the ANCAN High Risk Metastatic Advanced Prostate Cancer Discussion Group. I'm John, moderating tonight, and we want to start by thanking some of our sponsors for keeping the system running for us. This is that includes Bayer and Pfizer, Myriad and Myovant, Janssen, Telix, and Foundation Medicine. Rick has done a really good job this year in securing sponsors for us. Next, I want to welcome Jack G to the group. And what we usually do, Jack, is for new people, get a little bit of basic history down
Sure.
so that in the future we'll be able to intelligently answer your questions as best we can. So I'm going to ask you some, okay with you, I'm going to ask you a number of questions about your disease and when it got diagnosed and things like
Sure.
that, okay?
And I apologize for my photo disappearing. I'm having trouble with that, but I'm glad you can hear me.
I can hear you. Let me just change my screen so I can see the people that are on the phone. Did I miss anybody that's just only on the phone? There is a caller 02 here. I know caller 01 was John.
Okay, you have me, John Kish. Yeah, I'm not going to speak. Okay, I'm going to mute. All right.
Okay, thanks, John. There's another person on the telephone.
It's Moslin David.
Oh, your twin is also on here tonight.
Yes, sir.
Okay. So, Jack,
Yeah,
how old are you?
I'm 80 years old.
This calls for a new piece of paper. And when were you diagnosed, Jack?
Early February, end of January, early February.
Okay. Where are you located?
I'm in Arlington, Virginia, just outside of DC.
All right, another one in the area. Jim Marshall.
Who's that talking?
That's Jim
Jim
Marshall.
Marshall.
Anyway,
We got to get together for lunch.
There's a few people in the Washington D.C. area.
Okay, great.
Just don't invite Jimmy to that lunch, or you're going to be hearing ukulele music for the rest of the day.
if we have lunch, I want to go too. I'm right outside of DC also.
Who was that, Cliff?
Yeah,
Okay.
The Bicycle Man.
Yeah.
that's me.
Tell us about your diagnosis, Jack. You know, how did you get diagnosed, and what was your uh, what were your initial scans and blood tests like?
Trying to keep it short. My internist had stopped doing PSAs for several years, and then he started doing them again. And I had a physical in December. PSA came back at 8.2, I believe it was. Previously, the last they'd been in the sixes, but that was a couple of 3 years before that. So he took another test. The 8.1 was high. Took another test after about a month, and it was 10.1. I had anticipated some problematic news, and I had made an appointment to see a urologist at Hopkins in DC. They've taken over Sibley Hospital. So I saw someone fairly quickly, and then I very quickly had an MRI. I know enough to know that even though it wasn't a firm diagnosis, there was serious issues. 3 days later, I got I'm getting things mixed up, but I had a biopsy shortly. I had a CAT scan, then a biopsy shortly thereafter, and the uh, the MRI was pretty definitive. The CAT scan was very definitive. The biopsy was 100% definitive,
Yeah.
and then I had a PET scan, and it showed the cancer had entered the left seminal vesicle and two very two lymph nodes very close on the left inguinal side, very close to the prostate.
Okay. And tell us what has happened since then. It's not much time
Um,
since then, but have they started any treatment of any sort? Or
oh yes. I'm taking Orgovic, um, and I'm in the process now of deciding whether I'm going to take Abby for short. It's hard for me to pronounce Abiraterone or something.
abiraterone, yeah.
Right. And to me, that's a scary drug, but I've been doing a lot of reading. Um, I read the Stampede Report, uh, a couple of others, looked at the numbers, and to cut right to the chase right now, I have two questions that I am hoping to get answered by the oncologist. Uh, One is the number of older patients who benefit enough from the combination treatment, large enough to offset the added risk of taking the Abbey. And the second question related is there enough benefit if I decide not to take the Abbey for the 2 years that they'd want me to take it? Is there enough benefit to take the Abbey until the radiation, which hasn't begun yet, until the radiation is finished?
Or you're about to have
Um,
radiation as well.
I'm supposed to have radiation starting mid-July, the end of
Okay.
this month. They're being very
What
aggressive.
what was what was your Gleason score?
It was 3-4,
3 + 4. Okay.
and I'll just add this because I read something today that confirmed what I've been thinking. Ever since I've been a kid, through high school, through college, and afterward, I've worked out. I'm kind of compulsive about it. So literally 3 or 4 times when I was in the hospital waiting for doctors to come in, a doctor would come in and close the door, and then he'd come back and saying, "Are you Jack Gould?" And I said, "Yeah." He said, "Well, expected someone older." So I'm in pretty good physical condition.
Nice. Yeah.
Yeah, really. I mean, I feel good about that, of course, but more importantly, some of these doctors, I think, treat you the way your age says they should. And what I've been reading is no, they should treat you based on your fitness, mainly on your fitness, not your age solely. Now I'll
Jack,
be
Jack, a
now
lot of
I'll
times
be
what
quiet.
Oh, okay. Surgeons will think that way a lot. For example, let's say you just had only cancer in your prostate and no metastasis, local metastasis to the nodes or invasion into the seminal vesicles. In that case, surgery would have been on your potential treatment plan, and they would probably say to you, well, if you were a younger man, we'd do surgery. Now, they might look at you and say, but in your case, even though you're 80 years old and very fit, we probably maybe could do surgery on you, you know.
Well,
That's an example. But
can I
other than that, oh, who's that?
can I
Sorry.
just let me say something about that because I saw two surgeons and they all said, three surgeons actually, they wouldn't operate on me, but one of them
No.
said the reason is because at your age, and she was looking at me and she thought I looked young and fit, but she said at your age, the healing is such that you'd be wearing diapers the rest of your life. You'd be incontinent for the rest of your life.
Yeah. That's But you know what? The fact is, it's a moot point in terms of the surgery because you're metastatic, and so really,
Okay.
unless there was a very large mass of tumor in your prostate causing symptoms, I just don't think that you would be a likely candidate. But let me turn it over to the guys because you have a few high risk elements here. For example, the fact that you're metastatic and invasive, but you also have a relatively benign Gleason score compared to most of the guys here.
A benign what?
Gleason score.
Right.
But there are a couple of 80-year-olds in the room right here, right now, who can address some of your questions. And then we can also talk about your question about whether to add abiraterone to your Orgovix, um, because the fact that you're metastatic might argue that you should be on double therapy at least. But then you have that lowish Gleason score. So let's see what some of the guys think about that. Okay,
Sure. Thank you.
Okay,
take it
John,
take it away,
Yes.
guys.
is Jim Marshall. I was a 734 and we metastatic. Now, the first of all, to allay your fears, okay, of the Abbey, I have been on it now for 5 years. I am currently on a treatment holiday, and I am 79. Plus, I am fit, exercise on the bicycle, everything else, and so I don't find it that bad. There
Are
are
you
ways and way to mitigate.
are you on another hormone drug too, Jim?
Yes. Anyway, I am on well, I was on for 5 years the Lupron plus, okay, abiraterone for 5 years. I am currently on a treatment holiday now for approximately 9 months. Now, the point I would like to throw out to the brain trust, because the thing I'm hearing is the doctors are proposing to him essentially a triplet therapy. In other words, starting out ADT, radiation, and then maybe something after that.
No,
Within the
no.
protocol of
Yeah.
triplet, do you do the doublet before the radiation? I don't know that. I throw it out to the brain trust.
Yeah, they usually want you on hormone therapy for anywhere from 1 to 3 months before you start radiation because they are working together synergistically, the radiation and the hormone therapy. Um, one thing you can do, Jack, is ask your doctor if he's willing to put you just on Abby without the Orgovix, because both of those drugs do the same thing, only the Abby does it better, which is to say, the Abby will bring your testosterone levels down even lower than the Orgovix would. Might
Can
be
I
easier on your body as well.
can I tell you what they've been telling me?
Yeah,
The, the they've been telling me that the Orgovic uh, attacks the brings in the testosterone produced by the testes, but the Abbey only brings down the remaining 5% from the adrenals and from the cancer itself.
no, no. The Abby will block testosterone synthesis anywhere in your body. It's not just the
Right.
testosterone that's not covered by Orgovix.
Can we explain that a little better because both of you are right, but I think we can explain it a little better.
Well,
If you
okay, so
take
the better.
the Orgovix alone,
Right.
you may not be able to nail all the testosterone. So they add the testosterone to pick
Add
up
the
that
Abbey.
they add the abiraterone, the Abbey, to pick up that extra
That's
testosterone.
what I understand.
Right.
Yes.
Listen, Jack, listen. Just listen.
Okay.
However, if you were to take abiraterone alone, we now know, and we have anecdotal evidence in this group, that it can actually control all the testosterone, but it's not a common use. In other words, monotherapy abiraterone is really off label. You're supposed to get it with something like Orgavix or Lupron or Zoladex. So they're not wrong in what they're saying to you, but
Right.
Len is giving you better information because he's saying you could maybe just take the abiraterone and it would work just as well and you might have less side effects. However,
That's
you have to have a really forward-thinking genitourinary medical oncologist to accept that. Who is it? Are you seeing somebody at Sibley?
yes. I have two oncologists. One is the medical oncologist, and
Who's your medical oncologist?
uh, Chandler Pallard,
Right. Yeah.
That's a
and
G,
So,
right?
let me stop you right there. Okay. I'm sorry. In the interest of time, I'm
sure.
just moving it through. She's very good. She knows us. She gave a webinar to us. Tell her that you're with the ANCAN guys, and ask Dr. Palla if she might consider putting you on abiraterone, monotherapy abiraterone. Ask her.
Wow. All right.
The worst she can say is no. But what we know today, and Len and Ben, and they can address this, that we think we do better by giving you both. The sequence is usually start with the Orgavix, as Len said, then the radiation, and when the radiation's done, they'll add the abiraterone. That's normally how they go about doing it.
Wow. See, again, that's different from what she's telling me.
What's she telling you?
Well, she's saying, and I'm now on the Orgovic, and then I'm supposed to start the Abbey very, very soon, and then in mid-July I would start on the radiation, and they
You
want
know,
me on the they'd want me on the Orgovic and the Abbey
right.
for
So that
two
you
years.
can do it that way. I mean, you could
That's
do
the
it that way.
traditional way, right? That's basically standard practice. So no wonder she
No,
said that.
standard practice. They usually wait to add the Abbey until after. I mean, that's what we've seen. But I don't know, Len. What's your view on when you add the second line anti-androgen?
It's difficult to say because the practice is changing in the last
Yeah,
couple of years.
Hmm.
yeah,
Um, yeah, I mean, Rick, you're right in that just a few years ago, they would probably just put you on Orgovyx, do the radiation, and then possibly add Abby later
yeah.
if they saw your PSA rising. But being that your lesions are outside of the prostate, they probably would want you taking Abby sooner, in which case there's no reason why you couldn't take it before the radiation because it will shrink your prostate gland, giving a smaller target for the radiation.
Right. So what I would do is talk to Dr. Palla. She's very. I hope you're finding her pretty approachable. We found her really good. And has she given you the promise test yet?
I don't know. What is that? What do you mean?
Well, has she tested you for germline mutations?
I don't think so.
Either a
Okay, so
spit
here's
test
something
or
that you need to talk to her about. You need to say the Ancan guy said, I need a promise test because she's one of the principal investigators on the PROMIS test.
Oh, wait,
And
now I know what you mean, Rick. I filled out the form and that's all I did. I didn't get, if you mean the genetic test, they didn't send
yes,
that to me. And I asked her, how do I get that?
okay. So
And I haven't.
she's got you on. She's taken care of the genetic test. You also need to ask her, because this is standard practice and they don't do it enough. You tell her that you need somatic testing as well. That you
I don't
need
know what that means. All right.
okay. Well, we're going to explain it to you. It is the germline, the inherited you have in every cell in your body. It's what you inherited from your parents.
Right.
Okay. And
Yeah.
the somatic test is what you yourself made in your body. And you cannot pass that on to anybody, but you may have made mutations yourself.
Okay.
And it may
And
have caused your cancer.
and that's right. And it may influence how they treat you. So you'd need to ask Dr. Palla when you see her tomorrow, please, can you order a somatic test for me as well as the PROMIS?
All right. All right.
And what
Okay.
I would say is, what I suggest is this: we will, in the interest of time, because we're short today, let's come back next week, and the week we meet every single week, Jack, and we'll talk to you about the options for radiation therapy, because there are several options, and we
Okay.
should get into that with you.
Yes, it's a lot, Jack. It's really a lot. All of
Yeah,
us
no, I
remember
know.
our first few months after diagnosis. And speaking for myself, I was just insane with indecision and information. It
The, the, the
it's
the
just
one
that's a
question that was on my mind, and I know there's not a lot of time, but are the, is are, how much how much worry are the potential Abby side effects? That's what is freaking me out.
Jack G, this is Jim Marshall. Okay, as I say, there are a number of us who have been on Abby, and the side effects, there are ways and way to mitigate the side effects very well. Now, I sent you a message in the chat box. Okay, there is a box up in the right hand corner, and I sent you my phone number and email address. Give me a call and we can talk about it. Okay?
Jim, my computer's screwy. Can I quickly give you my email address right now?
Absolutely.
Oh, LEWGO, the number is 11 at gmail.com.
At Gmail. Okay, I'm about to write this down. 703 338.
615.
No, me.
Oh, go ahead.
703 338 7341. Alexandria, Virginia.
Oh, we're neighbors, just about neighbors.
Yes.
and
Okay.
Jim, call me in if you want another person to contribute.
Thank you very much.
Jack,
Hey,
there's
Abby has a problem with high blood pressure, and he should know about that. That
Yeah.
one of the
Yes,
biggest problems is blood
I
pressure.
will cover all those things. I wrote a paper on it.
Okay. Yeah, I've been
uh,
doing a lot of reading.
just one last thing, Jack, before we move on to the next new person. There is up in the upper right hand of your screen, there's two square little boxes. And there's a discussion that goes on during the meeting in those, we call it the chat.
Right.
So during the meeting, you can always check in there or you can always ask more questions. And hopefully, despite our crazy start today, we'll see you next Tuesday, okay?
I'll be there. I'll count on it. Thank you very much. I'm really glad I spoke to you gentlemen and I'm joining this group.
There are a
Thank
How
you.
did
couple
you find?
guys.
how did you find us, Jack?
I have a very good friend who's been fighting prostate cancer for 16 years, and there's more to the story, but he told me about you guys.
Okay. Is he a member? Can you tell us who it is?
Yeah, his name is Steve Brown. He
Oh my
lives.
gosh.
He-
Oh, okay. So you're a buddy of Steve's. Okay, that's fine.
Is that
Okay.
Rick? Yeah, he
Yes.
told me. Hey, he told me about you, and I'm talking to you anyway.
You're right.
No, but
'Cause-
he did tell me about you. Steve and I have known each other, I'm going to say over 40 years, maybe longer than that.
Okay. So you're referred by royalty. He doesn't attend this group, but he should attend it. And we'll be in we'll be in touch. We've got your back. Just tell Channing Palla that the Ancan guys said hello and Rick said hello. Okay.
I will certainly do that. Thank you.
Before I move on to Chip, a couple of guys raised their hands during that discussion with Jack. Was it about Jack that you wanted to speak?
I
Anybody?
think it was Cliff.
Yes, I'm in the Stampede study. So yes, I had started off with Lupron and abiraterone, and 3 months after that, I had radiation, 28 sessions of radiation. I was not sure if that was the right course of treatment, so I got a second opinion. And guess who I spoke to? Channing Paller. And
Huh.
she was very reassuring that yes, this was the proper standard of care. And as for side effects, yes, I do have high blood pressure, but I've been able to keep it under control. Of course, we all have hot flashes. That's one of the side effects, but we deal with it. I've been very successful with abiraterone and Lupron. My lymph nodes have reduced in size, and I do not have any active cancer at this time in any of my lymph nodes. So I'm doing really good, I think. That's from my
That's
last
great.
discussion.
That's
Keep
great.
exercising even if you start getting fatigued.
Yeah,
Okay. I have one very quick question for Jack before you move on. Are you a Wolverine too, Jack?
No, no.
Okay. Okay. Just wondered. Go ahead. Go ahead, Dr. Joe.
That
Dr.
reminds me,
John.
I'm supposed to ask also if he's a veteran.
I am.
Oh, you
Okay.
are.
We'll put you
All
also in
right.
touch. Well, Joe, when we get around to Joe Gallo, he'll tell you about another
Which
group that
branch?
was.
Yeah, and Jim Marshall will fill you in if you're a vet as well.
Yes. Yes,
I
I
mean,
will. So
I don't want to
carry on,
overstate it.
folks.
I was a reservist. I was on active duty. I never went overseas.
No problem. I can handle that. Trust me.
Okay.
Trust
You sound
us.
like an Air Force guy, one of the good guys.
Actually,
Amen.
I was
Amen,
in the Air
brother.
Force and the Navy. That's a long story.
I forgive you.
I appreciate you, Air Force. We appreciate you.
Chip, where are you on my screen here, Chip?
Top left as I see
Oh,
us.
there you
but-
are, top left. You're in the middle
Chip and
right for
Jane.
me. Hi, well,
Jane,
welcome to the group.
Jane's been by my
You
side
have
through this whole thing.
you have already been prompted as far as giving us a history, so I'm glad about that. But you want me? I'll just ask you the same questions. Rick, are you going to be taking notes about Chip?
Yeah, I'm taking notes on everybody.
Okay,
Yeah.
because I got notes on Jack. I wasn't sure if you were able to do that.
I'm taking both. Yeah.
Okay, so hi Chip, hi Jane.
Hello.
Jane, you're always welcome to come to group. Where do you live, Chip?
We're in Belgrade Lakes, Maine.
Oh, we had a new Maine guy not too long ago, didn't we? Anybody from Maine here? We had somebody. I don't know what group it was in. How old are you?
I think this may. Chip, were you in our Speaking Freely group last week?
No, I was in the veterans group for a first time
Oh,
last
in the
week.
veterans group. There you go,
Oh,
John.
that's
It's the
it. Yeah.
same gent who was in the veterans group.
Okay.
Well,
How old are
Jen
you?
knew completely.
How old are you, Chip?
I just turned 70 the other day.
Happy birthday. How long ago was your diagnosis?
I was diagnosed in April of 2021.
Okay, just a year after me. And what prompted the diagnosis?
Well, my annual, we use the VA healthcare system completely, both Jane and I do. And my annual exam included annual PSAs, all normal before 2017, started to climb a wee bit in 2018, 19, 20, 21. And 21, it went to 7.5. And again, I was told by my primary care, let's just keep an eye on it, just watch it. And I said, no, we're watching this thing go up. I'm not interested in watching it anymore. I want a referral, which he did, and I went up to the urologist who
I'm glad
I
you
think
did that.
I think I found a few kindred spirits here. Cycle Man, Cliff, and Jack, and Jim, who all work out. I do too. In fact, exercise is my drug to keep my mental health okay. And anyway, so I went up and the urologist said, well, if you only had our typical patient 5-year lifespan, I wouldn't offer a biopsy, but I'll do a biopsy. Anyway, said, but I'm not going to find anything because you're young, you're fit, you're well, not young, but you're fit, and you're all. I'm not. He called back with the result, and he said, well, I'll be damned. It's a high risk Gleason 9 grade 5 prostate cancer. Um, so I'll leave it there, but that's how it was diagnosed, and you can continue to ask your questions, Eric.
Okay, so you're a 4+5 or a 5+4 Gleason 9?
4+5.
You're a 4+5. Okay.
Yes,
And did you have some scans?
I did. In June of 21, I had a bone scan with no osseous metastasis apparent. I also had a CT of the abdomen, pelvis, and chest, also with no significant findings. So we were hoping it was all going to be contained within the prostate, um, so after whole lots of looking into what I wanted to do, I opted for, and the VA did a very radical prostatectomy,
Okay,
and that was done in August of 21.
August of 21. And then your prostatectomy, unlike a biopsy, which takes a tiny little bit of tissue, the prostate was entirely removed and examined under the microscope. And did it change your Gleason scores or anything?
It was no, it didn't. So not only was the prostate taken, so were the seminal vesicles and anything in the prostatic bed that he could grab, nerves and everything. Anything that he could find, he just kind of swept it out. But yes, they did post-surgical pathology on that prostate. At that time, it weighed 70 grams. It was an
Wow.
acinar adenocarcinoma, a group 5 Gleason 9, but
And
had clear surgical margins. Pardon?
the lymph nodes that they took out were all benign?
The lymph nodes, there was intraductal carcinoma as well as cribriform glands that were present. No lymph node involvement and no perineural involvement.
Okay,
So,
but there was
and the
some
margins were
cribriform
clear.
pathology.
Yes.
Okay.
So,
And
but
then,
I was hopeful. Go ahead. Sorry.
Did you get any genetic testing?
I did. I was referred, well, just this year, my PSA stayed low from post-surgical for every 3-month PSAs up until January of 23, when it hit 0.2. When I say low, I mean less than 0.01. At January, much to my severe unhappiness, it was a 0.2. In February 2.7, April 0.54, to May to 1.54. So it's been climbing, and, and so tell me again your question.
And all that, well, it was about genetic testing
Oh, yes. Yes, I was referred to a medical oncologist at that point, and I did, and he immediately, I asked for genetic testing, and we did genetics, and there was no genetic component that was heritable. I was interested in your statement about somatic testing. Is that the same as Decipher?
a decipher is a score created usually early on in treatment to help predict who might and who might not have recurrence in the future. In your case, what we would recommend is that the tissue taken out from your prostate be sent for genetics to see if there was a mutation that was involved with your cancer.
John,
Yeah.
can I say
Well,
something on that?
Please do, yeah.
We would we would prefer, to be honest, if there was more recent tissue than the tissue from 3 years ago, from 2 years
no,
ago.
no. Oh, so
He
what tissue would that be?
So, well, so if you have you had PSMA testing?
I have,
And
in February. No,
and what did it
I'm
see?
sorry, in March, I had a PSMA.
And what did the PSMA reveal?
One 4 millimeter nodule uh, in the pelvis, very close to the rectum, which upon um, another MRI, a confirmatory MRI using Gadavis 4, it nothing else lit up, just that one 4 millimeter
Okay.
little
So
nodule thought to be a
hold on,
perirectal lymph node.
hold on. And what is your most recent PSA level?
May was 1.54.
Have you had a test since then?
Last one was it was the end of May.
Just a couple of
Okay.
weeks ago.
Yeah, it was like two,
Oh,
3
so
weeks
the end
ago.
of May, the end of May.
Yes.
Sorry, I was thinking when you
Yeah, yeah.
right. So the discussion, here's what if that node could be biopsied, that would be ideal, but it's a very small target and it sounds like it cannot be biopsied from the location, but I don't know enough to be able to say that. The second choice,
Go ahead.
the second choice, and your PSA might be high enough, is to do what's called a liquid biopsy, which is where they collect the circulating tumor cells and they can do the analysis from the circulating tumor cells. But the issue for you is that you are on the margin as to whether there's going to be enough circulating tumor cells. Now, the VA does do and does offer all of this. And so
Hmm.
the best thing to do is to have the discussion with your medical oncologist and see what he or she recommends. Which VA are you being treated at?
Togus in Maine.
But
Okay,
I'm also with this medical oncologist. I've also asked for a second opinion, and I have a second opinion with a medical oncologist in Boston coming up at the end of June.
right. And do you know, is that somebody who works at Dana-Farber as well?
There's attachments, I think, to Harvard and Brigham and Women's maybe, and I googled
Probably,
his
yeah.
but
What's the
he's on a
name?
number of
Yeah, what's the name of the doc that you're going to see down in Boston?
Cho.
Cho?
Yeah,
CHO. Okay, well, we'll take a look
yeah.
and I'll get back to you through Jim Marshall or somebody. Okay, but yeah, you need to have a discussion with them. The worst comes to worst, they can go back to your PSA, they can go back to your prostatectomy, but things could have changed since then. That's the issue.
Sure. It's interesting that you mentioned the biopsy because that was mentioned as a possibility. But then actually my case, because that nodule was so close to the rectum, and I had some conversations with my urologist and also the medical oncologist, and because and originally my PET scan was done at the Alfond Cancer Center, which is out of the VA system, but it was a referral by the VA system, and the radiation oncologist there said that he would not consider radiation of that spot because of where it was.
Right.
Thought to be a perirectal node. However, because of that question, my case was brought up before the Boston Cancer Board, and radiation oncologist from within the VA system said that he would indeed radiate that, and so that's kind of where I'm heading at this point is to be radiated.
And you started with
But and in that regard, I started Eligard last 2 weeks ago now. Just Eligard.
Yeah. I mean, why did they not put you on Orgovix?
Good question.
Good question. He suggested that this Dr. Lee at Togus is my medical oncologist there.
He's a generalist.
He's a general oncologist who suggested, and I'm definitely afraid too, and I,
Of ADT.
of ADT and what it's going to do, because like I said, I found these kindred spirits here that are actually fit
Well-
gentlemen, and I'll go the fit part. I'm not so sure about gentlemen, but with me anyway.
Chip, let me tell you, I was an endurance athlete when I got put on ADT, and it was a great concern to me. And the bottom line for me was, yes, I lost some performance. I was younger at the time. It was many years ago. And I lost some performance, but it didn't stop me exercising. It shouldn't stop you exercising. You might not do as well as you did before. But what bothers me more is that these general medical oncologists they're out of their depth. You can get Orgovix at the VA. And he should have, I shouldn't say he should. If it were me, I would have asked for Orgovix. You probably didn't know. How long is this shot that he's given you? How many
3
months?
3 months.
When you're done with that 3 months, be sure they switch you to Orgovix, because you will recover much quicker if you get the opportunity for a holiday. It's probably a better drug. We don't know for sure, but we seem to think it probably is a slightly better drug. And you're on it for 3 months. You're on it for 3 months. That's
Yeah, right. Yeah. Well, the injection's there, so there's nothing much I can
That's
do about
right.
it now.
That's right. That's
What
right.
about
But the other question is the same one that we had with Jack Gould, which is, should you be getting a second drug? And the thinking is, today is yes. However, as you heard, we're not sure of the timing.
Right.
Dr. Paller's timing may be the best timing right now. What I said is probably out of date. So I stand corrected. But it's a discussion that you should be having with Cho and really switch to that. The other thing that I'm going to do is I'm going to reach out to some of my contacts at Dana-Farber for you and find out
Thank you.
who they consider to be the best GU medical oncologist in the VA system. And let's see if they come back with Cho. It could be Cho. I just don't know. I don't know the Boston system, but we'll do some checking for you.
radiation?
Yeah.
So is radiation?
So at this point, we're still looking at radiation, and although I'm not scheduled for that, I'm on the Lupron for 3 months, and then Dr. Batra, Batra, Sonny Batra, will unless things change, we'll be doing the radiation for 28 treatments at Jamaica Plain in Boston, starting maybe the end of August or so.
But
Okay.
is with his lymph node being so close to his rectum, that's the concern? Is the side effects going to be horrific?
Last thing I want in my life is a colostomy or a bag.
Yeah. That I don't know, and I think that's where you've got to get some real good advice. I mean, is Batra, which hospital does Batra work at other than the VA?
I don't know that. I know he's at Jamaica Plain. I don't know if that's his full-time job or not.
Okay, well, you, again, need to find out because we'd want to make sure that you had a guy that practices at Mass Gen or Dana-Farber. I would say Mass Gen or Dana-Farber as your radiation oncologist, and there are going to be some radoncs who practice in both places, and sometimes you get really really good ones at UCSF. For example, the San Francisco VA and UCSF have crossover some of the very best radiation oncologists.
Not just radiation oncologists, because that's my specialty. Is I obsessively research things, and they have some really good information on prostate cancer. It's just very impressive.
Who is that? Who
Uniform.
are you talking about, Jane?
No, the San Francisco.
Oh, right. Yeah. Well, unfortunately, we can't get you out. We can't get you out to San Francisco.
No, right.
Let's see what we can do in terms of finding who the best people might be at Jamaica Plains or what have you. We'll work on it.
Okay.
Hey, Rick,
Dana,
this is Henry. Can I bump in for a minute?
Go, Henry.
Hey, Chip and Jane, I'm going to send y'all my contact information through the chat window. I live in Birmingham, but I travel to Dana-Farber for my my radiation treatment. I was there for 40 treatments. And I want to talk to you about it and just let you know about my experience with Dana-Farber. Mark Pomerantz is my genitourinary medical oncologist there. I've also seen another great one. Her name is Alicia Morgans. And then Anthony D'Amico is who did my radiation plan. And I'll share all of that and more with you tomorrow. I'm
Appreciate it.
56. I was Gleason 9, and I had 8 of 27 metastatic nodes at prostatectomy, seminal vesicle invasion, perineural invasion, extranodal extension, and every bad thing you can have. And I'm on Abby, and I'm on Orgovix, and I had to self-direct the Orgovix after a loading dose of Firmagon. So I don't want to take any time from anybody else, but I'm going to send you that information. You can holler at me tomorrow.
Appreciate it.
Thanks. Sorry, Rick.
Thank you very much.
Yes, sir.
I have a
Excuse me,
question
John.
for
Chip and Jane are both doctors.
We're
Veterinary
veterinarians,
doctors,
but yeah,
I understand.
veterinarians.
Hey, we got it all covered now.
I have a question for Len and
Well,
Rick and
I'm
Ben.
no stranger to the word castration.
Yeah.
Be nice,
Does-
Chip. Be nice.
You mean
Uh,
be nice, Jane? I'm the snarky one of the two.
Len and Rick and Ben, does a person with some cribiform histology, has anyone looked at whether there's a I'm getting a lot of interference. I don't know. It's
Yeah,
not
it's from
showing.
Jack G. Jack
Oh,
G,
Jack.
could you mute?
Is there anyone that knows whether a person with cribiform adenocarcinoma is better off with one particular type of ADT or not?
I don't know. I mean, the issue with crib reform is that it tends to be more aggressive. But what I don't know, this is a Ben question really, is if crib reform is followed after initial treatment, what are the outcomes and what are the implications of crib reform down the road? I mean, what we do know is that crib reform compromises your Gleason score, but we don't usually talk about crib reform post initial intervention.
Okay, very good. It's just one more thing that makes me kind of want to see Chip on pretty aggressive therapy.
Mm-hmm.
That's interesting because I did not have crib reform on the biopsy, but I did on the pathology from the prostate.
Yeah, yeah.
And
I
what
think you
did they
buy
tell
it.
you, Steve? What did they tell you about the prognosis for the crib reform and follow-up treatment?
Uh, they they were uncommunicative on lots of different levels about my prognosis. I mean, the implication of having positive lymph nodes was something I really had to get off of the internet rather than from my team.
Mm-hmm. Mm-hmm.
Well, I think it's kind of a wonder that Chip got away without ADT for a couple of years now.
Yeah.
So, okay, well, I hope you stick with us. And you've got a number of decisions coming up in the next couple of months, it sounds like. And you're welcome to discuss any of them with us. There's people here who have been on everything that they can think of to throw at you. So we can give you a little discussion about that. So welcome to group. And
Well,
I'll see.
thanks very much. And for those of you that are looking outside, like the Dana-Farber and so I can't tell you how much I appreciate that.
Yeah, really
That's
great.
really helpful. Thanks. The inside track is always a good thing to have.
Yeah, we like Dana-Farber, but then of course you want to work with the VA system whenever you can.
Yeah, I'm not sure they would refer me to Dana-Farber, but I don't really know. But I also have Martin's Point Health Insurance, so
Oh, good.
TRICARE, so I can also go out that way too.
Okay. Okay. Any last comments from anybody before I move on down to the list?
Yes, Jack G, you have to mute your microphone, please. We're getting feedback.
I think he's on twice, so I'm gonna kick you out of the where I don't see your picture, and if God forbid we lose you altogether, come back in, okay? And hopefully this will take care of it.
Okay.
Now, there's there's no way I can get to everybody, so I want to make sure that if any of you have something that you really want to talk about now, please put your hand up or tell me or Rick on the chat so we make sure that we get to you today. Because, we hate, especially Rick, he hates to leave anybody off that wants to talk. We can probably go overtime, but call it to our attention if your question is pressing. Okay,
John, you have a hand from Steve Schuler.
Steve.
Right. I just a quick question to confirm what I think I know is I'm being told that we wouldn't put you on Abby because it's not shown in a clinical trial for PN1M0, even with all your bad features. But there is a clinical trial going on right now, and my response to Dr. Liu is basically, well, that's great that 5 years from now you'll know that I should have been on Abby 5 years ago.
Yeah.
But I want your best guess now rather than waiting for when the clinical trial confirms what you think you already know. Is that, am I being too aggressive there? I don't think I am.
So, could you clarify what Dr. Yu told you again?
That the benefit of Abby for node positive but not metastatic is not shown in a randomized trial. Basically, is what he said. And one thing I should note is I never had a PSMA PET. The Medicare declined to cover it. I decided to go ahead with treatment anyway, without fighting that battle. Uh, so so part of his reasoning was that you don't you didn't have radiographic uh, nodes show up. Well, yeah, they were never tested for.
You said you
Uh,
were node positive, didn't you?
yes, after the prostatectomy, yeah, they had 3 out of
Oh,
13
oh,
nodes,
okay. But it
and
didn't show up before then. I see. I see.
right, but I never had a PSMA PET either. So
Yeah, yeah.
Excuse me, Steve. This is Jim Marshall. Anyway, I was diagnosed through the fact that I had 2 of the large lymph nodes in the back were then positive, and I've been on and with Abby for, as I said, 5 years, and it's been wonderful.
yeah. Anyway, I just was hoping to get. I think I know I should push hard on this, and I am pushing hard on it. I I didn't actually. My response to Dr. Yu was not quite as snarky as what I just said, but that was the essence of it.
I don't really quite understand Dr. Yu's perspective there. Um, I mean, I'm like you. I was node positive. I was put on abiraterone very early on in my treatment. Um, can anybody understand what Dr. Yu was saying there? I guess we don't know.
I'm, I, I mean, I can say that I was node positive, and I started abiraterone in the same month, November 2021, that I started ADT.
Yeah, same with me.
Were you
Same with
guys
me.
node positive um, based on scanning, or were you guys node positive based on the pathology from the surgery?
Pathologic node
Pathology.
positive for me too. Yes.
Both.
Biopsy of the lymph node.
Yeah, biopsy of the lymph node and scans.
Okay, so biopsy of the lymph nodes. I guess let me just clarify that question. Um, were those of you who got abiraterone, did you get it on the basis of them seeing the lymph nodes positive from the surgery, or did you get it based on them seeing the lymph nodes from a scan?
Uh,
Surgery.
pathology, the
From a
biopsy.
scan. But I haven't had surgery.
Okay, so one from a scan. Jim
Okay, it was a
Marshall?
biopsy of an external lymph node in the back.
Yes.
Yeah, and I
So
had
they
biopsy.
saw that on a scan. Did they see that on a scan?
For me,
Excuse
yes, it
me,
was
it
on
was on a
scan.
CT
It was
scan,
Right.
lymph
Okay, on a
node
scan.
enlarged,
Got
and
it, got
it
it,
was
got it, got it.
biopsy.
On a scan. And Henry, did they see it on a scan, or did they see it from from the surgery?
There were only 2 equivocal. They weren't sure on scans. During my workup, and the radiologist called them non-specific, and so it was only at surgery when he did the super
Okay,
extended lymph
got
node
it, got it,
dissection.
got it, got it. Sorry, it's but yours was surgery. We got 3 hands up.
Those
Yeah,
might be
so a
the people.
mix.
I think the hands that are up, I was going to ask myself, Rick, are those the people that want to make sure to get in today? Or are those people that are responding to Steve's question?
I'm responding to Rick's question,
Okay, Gary.
and mine was diagnosed after lymph nodes harvested with prostatectomy.
Okay. So yours was from the surgery, correct?
Correct.
Okay. And you're on abiraterone?
Yes,
You're on
and
yes,
it was
you're on
prescribed.
abiraterone.
It was prescribed 1 month after the Eligard.
Yeah. I mean, look, I think what we're hearing here, Steve, is that there are a number of guys being treated in other places who are getting abiraterone. And some of them are getting it based on their PSMA scans or CT scans, and some of them are just getting it based on the fact that they had distant nodes at the time of their surgery. So again, I mean, as we said before, I don't know why Dr. Yu is not willing to give you the abiraterone. It should be covered by your insurance. And I would not ask him, tell him you want it.
Yeah.
Go in and say, I want abiraterone. And if he won't give it to you, then you may finish up having to change your doc.
Steve, it's not because you're on an androgen blocker, is it? You're not on like darolutamide or enzalutamide or
No,
something.
no, I'm
No.
only on Lupron.
Okay. All right.
I finished. I also got radiation.
Okay.
Finished that.
Yeah,
month
I don't understand it either. So yeah, talk to him some more. Dr.
Right.
Yu doesn't
Thank
seem
you.
like okay. Al Latimer, please.
Hi.
Hi,
Hi,
Al.
everybody.
Hi, Al.
So a quick update. I guess most of you know I've been on chemotherapy the last 6 months or so. I had 8 treatments. Just a little quick background. 8 treatments. When I started, my PSA was around 66. And after the 8th treatment, my PSA was down to 7.09. So I had a really good result from it. But the side effects had been advancing, and we decided to stop after 8 treatments. I had another PSMA PET PSMA PET after the 8th treatment, and my scan had much improved over the one before I started. But now, 1 month later, my PSA went from 7 to 12.7 in 1 month. So the cancer has taken off again as soon as I've stopped the chemo. And it seems like the consensus is that I should try some Pluvicto again. But I don't know. I'm kind of out in no man's land, and let's see if anybody else has anything to say about where things stand for me now.
What was your what was the rise in your PSA again?
It went
7
from
to 12.
May 1st, it was 7.0, and June 1st, it was 12.7. So it went up roughly 5 points, almost 6, roughly 5 points in a month. In 1 month, 30 days. So anyway, Dr. Scholes thinks I probably should try Pluvicto again. Dr. Singal is of the same opinion. And so that's where I'm currently headed.
How, what was the reason for stopping the chemotherapy when you
Um,
did? I'm sorry, I missed it.
I had 8 treatments, and the side effects were increasing. The neuropathy was getting worse, the fatigue was getting worse, um, and I was experiencing dry eyes and dry mouth, and
I see. So you don't want to
um,
go back to that because it
well,
was
um,
intolerable.
well, it wasn't intolerable, but I don't know. We were thinking maybe we could have some time off from it, but apparently that's not true. Um,
No.
that it rise that fast immediately. Um, so the idea right now is to switch it up and go back and do another round of Pluvicto, for which I'm not even sure I qualify since I've done it once already, but we're going to try to put it through and see what happens. Al, how are
Rick,
your
you were,
blood counts? How are your blood counts? Fine. They're fine?
Yes.
Oh, great.
Rick, you were really interested in that idea of a second round of Pluvicto. What, what,
Yeah.
what came out of that?
Well, what came out of it is that they seem to think in Australia that where they've done more testing that it is tolerable, and that was the best that we could find out. I think what's his name, Michael with an H, the doc
Hoffman.
in Hoffman. Thank you. Yeah, Michael Hoffman has been tested, and it is possible. Um, have you, Al? You're still with Singal? You didn't switch over to Belusic?
Well, I use Singal mostly because he comes up here to Broward County, and that's where I was doing the chemo, and Belusic doesn't. But I communicate with him. He knows what's going on. Um, I haven't posed this question to him yet, but I'm going to.
Well, I would put more faith in what Belusic says than Singal.
Um, yeah, well, and like I said, Scholl seems to think I should do some more Pluvicto as well, but I have not talked to Bolisic yet, so I don't know what his take on the situation is. That's one thing I haven't done yet. I wanted to bring it up tonight because I'm going to be away the next few weeks, so I'm not going to have a chance to get on the chat group. So I wanted
Oh, okay.
to at least plant the seed tonight.
Okay.
Well,
Al,
I mean, I do. Go ahead, Len.
are your lesions in the bone or soft tissue
Uh,
as well?
no, no bone at all.
Oh, okay.
No organs at all. It's strictly lymph nodes.
So what
Maybe
would you
they
guys
need to
do?
do
Go,
another PSMA scan before they think about another round of Pluvicto.
Yeah, I probably will have to have another PSMA scan before I start it if I do it. Um, but it just seems I had the same situation with the Pluvicto though. When I did that, I had a great response to it while I was doing it, but the side effects became intolerable. And well, I did all 6 treatments, but I wasn't going to do any more even if I were available. The side effects had just become intolerable. Um, but if I can,
worse than the chemo?
oh my, yeah, the dry mouth um, was really bad, and completely lost my sense of taste too, which
Yeah.
has not been true with the chemo. The dry mouth is I have some, but it's not intolerable.
So, Al, I mean, if that's the case and you were given the choice of two evils, would you rather do Pluvicto or chemo?
Well, I think at this point I'd like to switch it up and try the Pluvicto again and see if that will help kick the can down the road again.
My wife says that the worst thing that happened to me with the chemo, she's in the background here coaching me, that I became grouchy,
Not just grouchy, intolerable.
intolerably grouchy.
Yes. They could not speak to him. It was awful.
And that was on the chemo, right?
That was on the chemo, yes.
That
The
was on the chemo.
last couple of sessions, I don't know, I just was not very tolerant.
Well, it was the cumulative effect of all 6 of them.
You know, you heard that,
7,
you heard
right?
that cumulative effect.
Yes, it was terrible.
But I was having a really good effect on the PSA, so that
Yeah.
part was excellent. I mean, to take it from 66 down to 7 was good. And I was still responding, and I don't know, I was kind of in between about whether doing another one or not, because, you know, I still was having a positive effect. As a matter of fact, Singal wanted me to stop after 7, but I told him I want to keep going. But then the side effects just seemed to keep increasing, and decided that 8 was enough for the time being.
Well, it sounds like it sounds like both drugs are capable of knocking down your PSA as long as you're taking them. So therefore, it seems like it's a question of tolerability. In other words, it seems like it's sort of your choice, you know, which one is worse. And your
Yeah.
choice sounds like it's to go back to Pluvicto, because in both cases, you were able to take several doses until you got bad side effects.
That is correct. I mean, it really didn't start to sink into me with the chemo until about number 6 or 7.
Yeah.
And then the last one was significantly worse. So I hear.
Over the top.
How long ago was your last?
The last treatment was in, let's see, when was it? The early April. So it's been almost 2 months now. Almost 2 months ago. Actually, tomorrow will be 2 months.
Only recently.
So let me go a different route here. Let me go a different route. You are, because I'm just looking at your notes. You're BRCA2, right?
I was BRCA2 on one test,
But it's not.
but back about 5 years ago. But the BRCA2 has not been positive on any of the genetic testing I've done since then. So whether I'm really BRCA2 or not, I don't know. The most recent ones I had were done at MD Anderson, well, just about exactly 3 years ago now.
Okay.
And
But
BRCA2.
I think before I do anything else, you need updated somatic testing. And I do that before you go away. I think we talked about this before. I seem to remember we had a similar conversation not so long ago.
Yeah, and I have not pursued that, doing it
Right.
again.
You've got to pursue it because the BRCA2 came up on somatic, not germline, correct?
It
Must have
was
done.
it was with Foundation One.
Foundation Medicine. Okay.
It must have been, Rick.
Yes. So I think you've got to get some updated testing before you make any treatment decision. I mean, I'm really surprised that Schultz isn't even saying that. And just
He did not even mention it. As a matter of fact.
well, you know, if it were me, I'd be asking for updated somatic testing. You haven't been tested in 3 years. There's all kinds of stuff going on. You've been through all these treatments. The cancer could have changed significantly. When was in the last PSMA test, did it show the nodes that were positive?
Yeah, absolutely. There's I don't know, a dozen or so of them.
Okay, so what I would be doing is getting a biopsy of one of those nodes must be biopsyable.
Yeah.
And
Yeah. Well,
starting and tomorrow I'd call up Belusic and say, Dr. Belusic, first of all, I'd make my bed with Belusic and not with Sangal. He's away half the time. And it doesn't do you any good. And you've got to switch to Belusic when Sangal isn't there. And I don't think Sangal keeps up the way that Belusic keeps up. That's just my gut. That's a gut. I don't know for sure, but I think Belusic closely follows the literature. I don't know about Sangal. So number one, you got to make your bed with one of these guys. Two, whoever it is, you probably have to get another PSMA so they know exactly where those nodes are. Get one of those nodes biopsied, get it sent off to Tempus or Myriad or Foundation Medicine, and get some updated testing, and then decide what to do next. Because this is, in a sense, this is kind of like throwing spaghetti at the wall and seeing what sticks, because everything we throw, you respond for a few months and then you stop responding. And that's a puzzle. And a good GU med-onc should be trying to figure out why is it that we can't get something to stick with you? Is it because the cancer's changing? Is it morphing? Are we actually looking at something that's a little different, but we don't see any bone mets?
well, that's a really good point. I mean, after I did the Pluvicto, my scans cleaned up almost completely. There was almost nothing left, and but the cancer came right back. So
Well,
does that mean? So what is that? What is that? You know,
what
the
it means to me is the same situation that Mike Yancey has, who we should go to next, I think, because he said he wanted some time. But you've got some of your cancer is avid and some of it is not avid. And we're not getting the right treatment to the stuff that isn't avid, and it keeps coming back.
That could be that some of the cancer is just not showing, just does not have the PSMA.
So that means, so what they've got to do is they've got to do this concurrence where they do a PSMA scan and then separately, not the CT scan they do with the PSMA just for location, anatomical location. They go do a proper FDG PET, and then they have to overlay the FDG PET and the PSMA, and they've got to see what's going on. But nobody's doing this.
So that was done at UCLA after I finished the Pluvicto. They did both scans, and they were both clean. Well, the PSMA PET was almost completely clean, almost completely resolved, and the other test showed nothing. So the other test was clean. So
well, that's encouraging. That's encouraging because it suggests
no, that was let's see, when was that? That was, I kind of lost track now of what was when. That was in March of 22. So that was just over a year ago that was done.
And probably Rick is
and that was done at UCLA.
And Rick is probably thinking about the biopsy because maybe you can escape the whole dilemma by going out the back door with a PARP inhibitor. Who knows how that biopsy is going to come up now?
Right.
So he wants to see an update in case you can just jump the whole question.
Well, I've been on the Lynparza before, and it worked for about 6 months. Anyway,
there's something going on, and the first step that you need to do is, in my view, is to get a somatic test.
Okay.
And then,
Rick, I agree with that, and I'll get on it.
Okay. When are you leaving to go away?
Friday.
You know, you got to put your skates on because you really need to get this taken before you leave. I mean, push comes to shove, you could do it on blood, but you're better off doing it. You're better off doing it on the soft tissue. That's going to give you the best result.
Okay. I hear you.
Rick, I am going to go to Mike Yancey in a minute, but first I want to see why Bob Snyder has his hand up.
Okay, well, thank you guys. Appreciate it.
Okay, yeah.
I'm up.
Yep.
I was diagnosed in 2014, and I've been on everything there is to get. And well, the last I started on Pluvicto in December, but I had very little PSMA, but they decided to try it anyway. My PSA was all the way up to 63, and I had 2 treatments of Pluvicto, but the PSA kept going up, went up to 99. And then they put me on Nubeca. I was on that once before, quite a while ago, so I went on the second time, and it brought my PSA down to 53 pretty quick. I was on it for 3 months, though, and then it started going back up. And then they just put me on abiraterone for the second time, along with the dexamethasone.
Yeah.
And right now my PSA is probably around 63, but I'm going for a blood test Wednesday to see if the abiraterone's working or not. The only thing else they suggested for me next would be try cabazitaxel chemo again. I can't do the docetaxel. I had a real bad reaction to that, and so I don't know. I just wanted to ask you what you thought, what else I might be able to go on next. I think they told me there might be some trials in Buffalo that I could go try to get into, but I don't know. I might try the cabazitaxel first.
Seems like if there's a standard treatment standing next in line, it would be appropriate to do that rather than a trial in general. Anybody disagree with that?
I'm sounding like a broken record here, but when was the last time you got somatic testing, Bob?
Yeah, quite a while ago. My gene mutation is at ARL702H. But yeah, I can when I'll be going in to see the oncologist, and I'll see if I can't get that done again.
So again, I mean, I think you're in Rochester, right?
Right.
And who's your doc?
Dr. Victor at the U
Yeah,
of
I think
R.
I
Yeah.
think we've had this discussion before. I mean,
Yeah.
probably Dr. Van V is a better option. But don't they work together?
They're in the same hospital, but I don't know how much they work together. I've never gone to him, but yeah. How do you spell his last name?
Tony Fig.
He might not
Are
be
you
on
with?
yet. Oh, there he is. There he
Yes.
is. Yep.
Come on, Tony Fig.
VAN,
Spell his last name.
VAN, VELDHUIZEN.
Okay. Thank you.
I can put it in the chat window.
What do you know much about Dr. Victor, Tony?
No, I've never heard of her. I just looked up a little while ago, but there really isn't much information. It looks like she's just a general oncologist, radiation oncologist.
She's a radiation oncologist? I thought she was general. Is
Yes.
she a radiation oncologist?
She calls herself a physician.
Okay, let's have a look here, because if that's the issue, then I think you should be moving to Vanderhuysen. What's her first name?
Adrian Victor.
Adrian Victor Rochester. No, she's not a radiation oncologist. She's not a radiation oncologist. I mean, she is a medical oncologist, and but I don't think, and I think we've talked about this before, I don't think she specializes in prostate cancer. And
Yeah.
and we strongly believe that you need to be with a doctor that specializes in prostate cancer. And
Well, I don't think she does anything else besides prostate cancer. But I would think Strong Memorial, U of R, I don't think they would put anybody with anybody else that wasn't specializing in that. But.
Well, I don't know, but she didn't train anywhere that is known for prostate cancer.
Okay.
And she doesn't state anywhere that she specializes. In fact, it says hematology oncology, so it would make me think that she's a general oncologist. And my feeling is that you really want to be with somebody who is known for their knowledge in prostate cancer, which is Dr. Van V.
Okay.
Now, how easy it is to switch from one to the other, but I think you can easily ask her how much of your practice is prostate cancer.
Okay, I'll do that.
And because, it seems like what they're doing is they're recycling you. I think, again, we need to see if we can find any hooks in your blood work, Bob, in your analysis, your somatic analysis, if there's a little hook in there maybe for something. I mean, you have some strange mutations, none of which are familiar to me, but you do have mutations, and there's so much going on. I don't know. Dr. John, what would you say?
Sorry, Rick, I was typing something right at the time. I'm sorry. What was your question for me? Would you mind saying it again?
My question is, what about switching docs? And I mean, it seems to me that they're just throwing Bob around on the roundabout. He comes off one and then they put him on another, and it's just sort of round and round.
Well, I'm really big on second opinions, even without switching.
Yeah.
Even though your PSA is going up, stick with it anyway.
No. John said that he's big on second opinions, and maybe that's,
Okay.
you either get a second opinion from Van Veltheisen or get out of Wilmot,
Okay.
and get a second opinion in Boston.
Okay.
Or in New York City.
They might even do it on a video call. It's just a consultation. It's not like you're asking them to take over your case.
Okay. All right. One other thing I just wanted to mention to you. Have you heard many people having good luck with Keytruda?
Well, yes, but you see, the issue with
I know you need a
Keytruda
certain
is
speed for that.
right, and so so that's another good reason to do this testing, to see if you'd respond to the Keytruda.
Yeah. I know a guy that's on Keytruda, and his PSA was up to 1,000, and for the last couple of years, it's been down to 0 on the Keytruda.
Well, again, this is why it's called precision medicine, because we try to match the right treatment to your own genomic profile. And yes, if you're MSI high and you have the high tumor burden, yes. But this is what Dr. Victor should be thinking about. And she should be ordering this to look for this for you rather than recycling it, which makes me think she's not really a genitourinary medical oncologist.
And when you've been on immunotherapy a couple different times, I've been on a couple different ones, that can change your genes, right?
Well, different treatments. There doesn't have to be immunotherapy. Treatments change your somatic makeup.
All right.
Because your cancer's trying to figure a way to resist the treatment. It mutates, I'd like to go on now to Mike Yancey, and then Rick, after that, I'm going to ask you what we should do about time. Mike, are you still on?
Yeah, I'm still on here. I'm going to kind of read some notes here so I can keep this thing succinct as well as stay on track. But just kind of start at the highest level with a little background. Of course, I've got lesions on my spine that pretty much none of those, not very many of those, if any, express PSMA. And of course, that caused us to stop using Pluvicto, which was doing a very good job in a lot of my pelvis, hip area. We stopped that in December and moved to topoisomerase and carboplatin chemo then in order to try to address the growing lesions on my spine. And as Rick kind of mentioned a moment ago, I do have a large combination of bone-based lesions, but then I've also got a lot of tissue-based lesions that are actually growing out of various vertebral column locations, pretty much from my head to my pelvis. And I had a lesion that come up that really, starting in March, has really incapacitated me to a large degree, is on the right iliac wing, and that lesion increased. And the topoisomerase and carboplatin chemo did not really seem to impact that in any significant way. Then I just recently found out through some new scans that I've got some new lesions on my L4 and L5 vertebrae that are not showing up on the PSMA PET scan. So most likely that's not putting out expressing any PSMA, but that has started pressing on a lot of nerves and things like that going down my legs, which has further limited my ability to walk without a walker, etc. So all that. So I also have a lot of, because I have not been on Pluvicto or anything like that, I've had significant PSMA expressing lesions with SUV increases in a very large number of my bones, mostly in my hip pelvis area, but also have found a few that put out PSMA in the bony structure linking the skull and the vertebral column, as well as C1 and C7 vertebrae. So that's just kind of and I've also got a shoulder socket, sixth rib, socket of the ball and socket of the right hip joint, etc. So with all that said, some of the treatments I'm currently going on now is really being driven by, let's just say, life activities. In other words, I've got a motorcycle trip I've been planning for over a year that heads out July 1. So the entire team is working hard to get me patched up for that. So what am I doing with respect to treatments right now? Basically, I had radium-223 infusion on May 17th. I did have a strong reaction that we assume was due to the treatment, killing a lot of cancer cells, bad chills, fever up to 100.9, severe pain, and I had to be assisted bed on the night that I got the infusion. However, things have improved significantly since then with respect to that. And we're going to look for another infusion somewhere around June 14th, assuming my blood counts hold up. Because today I began another infusion of cabazitaxel and carboplatin chemo. And then on top of that, today we also started 10 rounds of radiation to that right iliac wing. And we're also going to tomorrow begin to also spot radiate that L4 and L5 vertebrae in hopes of relieving some of that pressure pressing on my nerves. One other thing I should mention, as we're throwing everything with the kitchen sink at me, is I began bat treatment on June 1st. That was my first. Boy. And we'll do another one around June 28th. And so what we're going to do is get me on that motorcycle for a month, and then we'll come back and take another look at the long term. But things right now, if I get rid of the pain, I can do pretty good. That's a summary.
Fascinating combination of aggressive treatments. I'm very curious about whether your radium and your Pluvicto overlapped each other.
No, they did not. The Pluvicto I stopped in December, and we just started the radium on May 17th.
Okay.
Go, Mike. Go for it.
We're going for it. That's what we're doing. People think I'm crazy, but we're going for it.
Holy smokes, anyway, how big of a bike?
1800 Gold Wing.
Oh,
jeez.
A Strato Cruiser. All right.
Got to ride something comfortable.
I've been in cars with smaller engines than that.
Suzuki.
Mike, I'd be a little concerned about getting the 2 chemo drugs on top of the radium. Seems to me you're putting your bone marrow at significant risk.
Yeah,
I would talk to your docs about that.
Yeah, we're watching it really, really close. In fact, I'll have another set of labs done. I had the chemo today. We're gonna have another set of labs done next week, and that's gonna have a lot to tell us to whether we can go forward with the radium 223 or not. Because you're right, it may put me too far down, and I may not be able to keep it up.
Yeah, and Rick, you got to help me out here. What was the name of the doctor who was at Tulane and then he moved to Mayo? Sartor, right. So I listened to a lecture he gave not too long ago where he said he doesn't use BAT unless there are just a few bone lesions. He thought that if there are multiple bone lesions, it could accelerate the growth of the cancer.
Yeah, that's one of the things we're watching. Of course, we're kind of taking some risk here. We're kind of, like I said, trying to throw everything at it. I do have some mutations as P53, which some of the BAT semi-successes, I'll call it, have shown to be more successful in people with that particular mutation. So, yeah, we're doing a lot of things simultaneously. I'm willing to take the risk, and we're going to watch things closely. So that's kind of where I'm at.
Did the protein analysis point to anything?
No, on my latest biopsy, believe it or not, even though I expected significant differences from the latest proteomics report, there really were not very many changes from what they found on the non-producing PSMA lesion on my back last October. Very similar. And then I just got all the reports in today from Foundations and Tempus also, and some changes, but for the most part, if you look at my mutations over time for the last 2 years, there's been the addition of quite a few mutations. Not deletion of very many, kind of depending on the company who did the work. You'll find the biggest variation between the companies themselves.
Yeah.
Yeah, I mean, my biggest concern, and you know this yourself, is that your bones are fragile right now.
Yep.
And just holding up that enormous bike could be dodgy. I mean, just the weight of that bike, you put a foot down and you're not rightly balanced, and that would be a real concern. A fracture. That's what I would be concerned about. I mean, I don't have to tell you, but I think it's a concern, Mike.
Oh, it is most certainly. I won't deny that at all.
How about a trike, Mike?
Nope, I might as well go walk down the road.
Cure it.
I have a 400-pound KTM you could borrow if you're willing to be seen on it.
But no, I understand the risk, and like I said, it's been a big priority for me, and I'm just one of those risk takers that I'm gonna, with the help of my doctors, to get me patched up, I feel good enough, and what have you, that we're gonna take the risk and go for it. And I've got a good friend that's gonna go with me, and as I've said, we've also added some insurance to our insurance plan, fly me home if need be, and have credit card will travel if need be.
Mike, are you on Xgeva?
Oh,
No, no, I'm not at this point. That's something I'm considering getting on, but I haven't started it yet.
Yeah, they don't even recommend taking radium 223 unless you're on Exgeva, because when they did that, people had multiple bone fractures.
Yeah, that's a conversation I need to have this week with my doctor when I see him here in a few days.
Len, that's exactly what I was going to ask. But even along with that, have you had a DEXA scan lately?
Yeah, I had one in March.
Okay, and did that show like
It actually
osteopenia
showed
or?
it showed me to be pretty consistent from a bone density perspective with a scan that I had done in 2017, long before I got cancer.
All right, well then I'm with Len. I think I have to look at Exgeva Prolia.
Just
Very
so
good.
that you know, Mike, if you did want to get Pluvicto, there is no wait list anymore. The supply is back up to normal, and we've been told there is no wait list. And I just saw that one of our guys is starting it this week, so the Pluvicto could be it should be available. If it's not, please let me know.
Okay,
But
yeah, that's something, as you well know, yeah, that's part of our challenge is we're fighting two battlefronts, and Pluvicto worked really well with one front and didn't work with the other, and now we're finding the chemo may not be doing as good as we thought it was either. So we've got some real challenges.
Rick, what
yeah,
do I do now?
well, why don't we find out? We've got no hands up. Let's find out who. I'm happy to take over from Dr. John because I know it's getting late for Dr. John, and so
Well,
that's tough.
now it is late for me, but now I'm all wired up by doing
Oh,
Zoom.
okay.
I got
And
eight. I got 8 people left still.
Dr. John's been working on the farm as well today. I think he's been cleaning out fish ponds, which is why I wanted him to speak to Joe Gallo, but I don't know if Joe's still here. But anyway, let's see a show of hands who still would like to talk today, because between John and I, we'll hand it. Just use the react at the bottom of the screen and just click on the react at the bottom of the screen and show a hand.
So
Frank
Frank is
Fabish,
one.
Richard.
Richard.
Okay. Anyone else? Anyone?
I've got to go. I know I'm on your list, John, but hopefully I can get in next week.
Well, we could take you first, Mark. Why don't we?
Okay.
Can we take you first? Is that okay?
Next week. Oh,
Now,
right
no,
now.
right now.
Yeah, I could do that.
Okay, so let's go with Mark, and then we'll go with Richard, and then Frank. Is that, or Frank then Richard? If that's okay. If you guys want to, we'll hang in.
And for the rest of you guys, if you decide to go, go ahead. We'll be here. If you don't, and we'll definitely see you next week. I can keep your names on the list here.
Yeah, and again, our apologies for what happened at the beginning. It was a GoTo issue, and we lost half an hour. And what can I say?
Go ahead,
Sorry,
Mark.
we're sorry.
I'm just looking to see if anybody has any ideas to help me. After 3.5 years since I finished my radiation and 1 year since I went on a total drug holiday, I'm now having urine retention problems. And my urologist has tried a few different things. She did a urethral dilation early in the week, which you don't want to do one of those. It's pretty painful, and it was with the hope that then I'd be able to pee all right, and I couldn't pee at all. So I had to have put in a catheter for 2 days. We took it out, and I still couldn't pee. I've got one back in.
and now they're saying leave it in for 2 weeks and then we'll take it out and see. I just wonder if anybody's had any experience of other ways of dealing with. Basically, I've got scar tissue left over from the radiation, which didn't bother me for 3.5 years, but the urethra is just so small. I can't pee sometimes.
See, we had a guy not too long ago who ended up with a percutaneous stoma. I don't know. Anybody have any experience to add to this?
Well,
For that other guy, they had a lot of trouble doing his dilation and his uh, urethral enlargements and things like that. I don't know if it was from radiation, and I wish he was here tonight. What were you going to say, Rick?
I I think that I think I'd like you to review this with Mac.
Yeah, I plan to.
Okay.
I talked to him about it a while ago, and he said, let's wait and see, but I got to get back in touch with him.
So you got to get back and say you're going through this, that, and the other, and I'd like you to review it with Matt because he's going to have a bunch of experience. It may be that that you need more skillful a more skillful and experienced urologist, Mark.
Could be.
I don't
Actually,
know.
my urologist is really good, but there's some procedures she would recommend, but I can't get them done here. I'd have to either go to San Francisco or up to OHSU. So that's sort of the next step.
Well, I would ask Mac. The guy that I think is pretty good on that stuff is Max Meng at UCSF, but it might also be he seems to be the go-to guy for the non-oncology stuff, but there may be others who are good too. But Mac's going to tell you because he's got to have seen this before.
Yeah,
and I would get.
He told me that you can be 4 years out from radiation when you first have problems.
Yes. So
no, I just threw it out in case anybody in the group had any experience, but I'm sure Mac can steer me in the right direction.
Well, I mean, we do have guys with plenty of experience on this stuff before and after. They're not on tonight. I mean, like we had this older guy last week who was 80, I think, who has a suprapubic catheter for the same reasons. And we have other people that have these issues and have catheterized. The big issue with catheterizing is avoiding getting a UTI.
Yep, I've had that already.
I know, and it's real hard. I just kind of think when it gets to be this sort of complicated, you want to be at either UCSF or OHSU, and given your history with, and that you've got such a good doctor, and it arises from the radiation. I mean, I thank God I didn't have issues, but I had radiation cystitis 3-4 years out, 5 years out. I didn't start till 3 years out, and then I got intermittent bleeding for I don't know how long. And I made a deal with my urologist, and in the end, they did a cystoscopy, and they just saw the irritation. There was nothing serious. But so I get it, and this is what can happen. But I think that Mac will point you to the best doc, and he'll get you an appointment quickly.
Yes, great. Well, thanks, Rick, and thanks, guys. I really do have to go, but see you all next week. And
well, let me know, right? And if you need any help with Mac, tell me, okay? But sometimes he answers me, sometimes he doesn't. I mean, he walked up and banged me on the shoulder at the GU ASCO. I didn't even have to say hello to him, and I was really surprised. So, but he does know his stuff, Mark.
He does.
He really
Yeah.
does.
Okay. Well, thank you, everybody.
Okay, very good. Um, Richard?
Okay. Oh, I am on. Just
Yes.
a update. I'm still the blood and test PSA is still undetectable. Testosterone is less than 4. I've been on Abby now for a year, and the ADT uh, with the what is it, Eligard, and it just keeps going. The last CT scan showed uh, the pelvic lymph nodes. One of them is increased a little bit in size, but all the nodes in the uh, lungs are just stable or being reduced. So we're just year after ending chemo. I'm just going along. I don't know how good any of the markers are since I started with a PSA of 2.
Yeah.
So um, that's just the way we're going. The idea. Oh, by the way, separate subject. It'd be good to get the guys in the DC area together. I know Jim Marshall and I have. I asked Cliff, and he said he would. We just need to uh, plan that, I guess.
Absolutely, Richards. Also include in there Gary Peters.
Okay. And I noticed there's Joel Blanchett in Reston. I don't know if he's interested.
I'll see.
Okay.
Okay.
Well, I'm gonna nominate. I'm gonna nominate Jim Marshall. And Jim Marshall, you can reach out to me, and I'll give you any emails you don't have, and you and I will coordinate, and then we'll try and set something up for the guys. But I want to
Yeah.
come back to Richard. Richard, remind me, what's your last name again?
Crammond.
That's it,
C.
Crammond.
Yeah.
Got it. I got it. Richard, what is it? What specifically can we help you with tonight? What is on your mind that you
I
need
guess
some help?
just what we're talking about, Abby. Yeah, and the dexamethasone, which, by the way, is they changed uh, to go to that after the prednisone. I guess was not as effective. So we'll see in the next few weeks what the CT scan is there. But and
But when you say it's not so effective, your PSA you say is still undetectable. So is it the scans that are getting worse?
yeah, that the scans, remember I've got that weird
Yep.
foamy gland and no Gleason score. Um, so we're just the scans are the important thing. The bone scans are all coming out clear.
Okay.
No,
So what is? I mean, I'm sort of trying to pick up what is worsening for you. What is concerning you?
Right now, there's two, in my mind, options. Go back on chemo, and I sailed through
Okay,
chemo,
hold on a minute. Hold on.
and
Hold
come
on a
back
minute.
to
Hold on.
Prevento.
Hold on a minute. Why do you have to make a change right now? Your PSA
Oh,
is
I'm
low.
not
Your
going to make
bone
a change.
scans. What is it? What is it that's getting worse that makes you need to change your treatment of the Abbey?
Nothing right now.
Okay.
Uh,
So if you're stable right now, if you're totally stable, if the scans are not getting worse, then if it ain't broke, don't fix it.
I've
You
heard
know, for
that
us to,
before.
right, but for us to talk about what we should do, we're not ready to do it. If I understand you don't make PSA because it's this foamy gland, but if the soft tissue scans don't show that the disease is worsening, then there are some options. One is to go on a holiday, take a chance, come off and see what happens. Another is just to keep taking the abiraterone. But to start talking now about should you do Pluvicto or should, you know, or different chemo, there's no reason to do it. I mean, what
I
did
agree with you.
I mean, Dr. Allen and Dr. Makovsky, are they satisfied with your progress?
Yeah.
So
Right now, as long as I'm that stable.
So what would you like for what is it you want to ask us? Should you change? Should you make a
No,
change?
not should I change, but in the future, what way should I go? Or
We
would
don't know because when you go to make a change, we're going to say to you, get a somatic test and let's see what it indicates. You may be like the guy that we were talking about before that Bob was saying, you may be a good candidate for immunotherapy. But we
yeah,
don't know
I've
that.
gone through two rounds of the somatic and the what's the other germlang, including promise, and I'm I have no matches on anything there.
Okay, but when was the last time you did a somatic test?
About 3-4 months ago.
Okay, so if it didn't show anything, we might want to test you again when things change. And but you know, if you come in next week and you say, because they should be scanning you frequently because they can't rely on your PSA. How often do you get the CT scan?
Every 3 months.
Perfect. So the next time you get a CT scan, if you see a big change on that CT scan, then we can talk about what to do next. All I'm saying is there are things to do, but the foamy gland is very rare. We don't know a lot about it. I mean, nobody does. You know, probably Markovsky knows more about it than anybody else, and you're seeing him. And then we could talk about you. But to sit there and worry about what to do next when you don't need to do anything doesn't help you and doesn't help us. But there are things out there.
Okay. I agree. I have no problem with that.
Dr. John, you're the psychiatrist around here. This is really you. I should have let you handle this one.
I think that I'm glad, Rick, that you pursued it to make sure that there wasn't something that we weren't aware of that was worrying him. Uh, I think if we can convince you, Richard, that there's nothing to think about quite yet, that would be great. You don't have to think about anything yet.
I'm not worried about it that
Okay.
way.
I would like to, if it's okay, I would like to just move on to Frank and save the last 5 minutes for him, Richard, since I don't think we have a problem to solve there. Frank?
Well, I won't take up 5 minutes, but it's one quick question. My A1C is rising. I of course have diabetes, and my pharmacist, my diabetes pharmacist, wants to change me from glimepiride to metformin to see if that will impact it. And I was just asking for those, if they've been on metformin, what to expect.
I'm on metformin. I don't think you have to expect much of anything. If it bothers your stomach, you just go a little more easy on it. And if it doesn't, I think most of what the metformin does is going to be invisible and you're not going to be able to feel it. Some people even feel that it's a good drug for prostate cancer. And there are some rare side effects which they can monitor just by doing blood tests. So I bet you're not going to feel a thing. Anybody have any trouble with metformin that's here tonight?
Oh, I haven't taken it, Frank, but I've known people when they started it. Now they didn't switch from another diabetes medicine, so that may negate what I'm going to say. But they started them on 1,000 milligrams, and it screwed up their tummy. And we had heard that you should maybe try 500, and then you can maybe titrate up, but try 500. They did that, and they did fine on 500. And I think eventually they got to 750, and we've known 2 or 3 people like that. So they'll probably start you on 1,000, but if you're nervous, they can start you on 500. How much are you taking, Dr. John?
500.
500. So
Yeah, my diabetes pharmacist wanted to be cautious and start with one pill, 500,
Yeah,
and then if I can tolerate it and if it's beneficial, then go to 2 pills to 1,000.
that's great
I mean,
advice, Rick, I think.
that sounds right. But the one issue that you've got to layer on top of all of this is that it's not unusual after you've been on your ADT drug for as long as you have, that these numbers are going to worsen.
Mm-hmm.
I mean, that's what the ADT drugs do. You've got this metabolic syndrome, and there's a whole bunch of people. I mean, I see Jeff Marchi looking at his phone or something there. He's a guy who's had trouble managing he's had to manage his metabolic syndrome whilst he's been on ADT. Right, Jeff?
C'est moi. My metabolic syndrome, I'm not exactly sure what you're getting at there.
Your diabetes.
Oh, I've really never had a problem. My PSA in the last my A1C in the last 7 years has only gone above 5.6 twice. So I keep it under control quite well. But I used to eat ice cream at night with fudge on it. Can't do that anymore. I can eat a little something sweet, but that's it, once a day.
Okay.
And
Frank
I
Favish,
eat
how are we
fruit.
doing? Frank Favish, how are we doing on the sweets? Are we good or are we not so good?
No, I stopped them about a month ago.
Well, give yourself some time, because that may be better than the switching to metformin. That could make a big difference. Dr. John, you know medically about this. How long would it take to resolve that? Is it immediate? Does it take
No,
time?
it's not immediate because when you do your A1C, it's measuring cells that last about 90 days in the body. So there's a delay. So yeah, it could be a couple of months before it really shows up in your A1C if you've changed your diet.
See, that was really helpful from Jeff. That's a great contribution. I mean, it is important. I mean, those tubs of ice cream are very appealing. I won't ask for a show of hands as to how many people have a tub of ice cream or half a tub every night, but I bet there's more than one. And it's like, oh well, the drugs will take care of it. The drugs, sometimes we have to take care of it. It takes a little. I see Henry laughing there. I don't want to think about what he does to that refrigerator every night.
Wear it out, Rick. Wear it out.
It's wicked, isn't it, eh? I know. Who likes Rocky Road, or is it mint chip? What's the favorite flavor on here?
Chocolate peanut butter double fudge.
Oh, no.
I agree with the chocolate peanut butter.
Oh, geez. My sugar's
See,
going up
guys, it
just
was
talking
worth
about it.
holding on. It was
I am
Well,
worth holding
judicious. Green tea is the only thing. See, green tea is good for you.
you mean green tea ice cream, right? Well,
on. At least
for Jack and Stuart and Neil and Lynn and Joe G and David, I'm sorry, and hope I'll keep your list till next Tuesday, okay?
yeah,
Hey, let me add
I'll write
let
to
me
a
add one
couple
thing
of these
before
guys.
we go. Frank, Google ARM-K of the Stampede trial. They're studying metformin and its possible oncologic benefit in the prostate cancer realm. So I think Rick's completely right about diet being the main thing you should consider, but that metformin is being actively studied. ARM-K, ARMK, that's a multi-platform study, Stampede, and they're looking at whether metformin may have some efficacy for in the advanced prostate cancer setting. Thanks. Sorry to
All
Okay,
steal another minute.
I
Thanks, Henry.
appreciate that.
No worries. And yeah, I'll get back to a couple of the guys. I know Stuart had a really interesting situation that John and I are both aware of. We would like to have raised, and I'll send him a note. And Neil wanted to talk about pectin. Some of you guys I'm sure, have looked at pectin and if it really has an impact or it doesn't have an impact. So we'll get these things discussed later on. And then we never really did have much of a discussion about Captain Joe's koi pond and what Dr. John's been doing cleaning out the fish at his friend's farm. But you guys have to get together on that, right, Captain Joe?
You you got it. It's one of those things. I've got there's over 2 dozen in the pond. It's 20 by 15. So yeah.
And let me say, Joe, because I checked, they've got the same heron problem that you've got.
Yeah, the damn heron like to live there, and right now I have waited unusually long to pull the net off from the winter time. So I'm getting ready to do that. But the heron got down. I could send you I won't send you the picture, but I could. Uh, there's one heron that's sitting there looking awfully pissed off
Yeah,
that he couldn't get in.
get
There
out your
there's there
shotgun.
the herons stand to like 4 feet or so tall and a wingspan of over 6. So that they're not tiny little birds. They love your fish. They love the smaller ones better.
They go down smoother. The little
Yes,
ones, they slide right down. Those big ones give
yes
them
they do.
indigestion.
Yeah, I use a sprinkler type system, but I haven't pulled the net because the sprinkler system's not working right. Because that's supposed to scare them. You can't kill them. It's illegal to harm them. So you can only
Okay,
chase.
Dr. John, did I give you a good referral to Joe or not?
Oh yeah, yep.
All right,
Like
guys.
you say, it's always good to get a second opinion. And make sure if you're in a pond, make sure you have a lot of aeration. Yes, we Okay. do. Yeah. Because I lost a few my first summer where there was the electricity went out and I had nothing, and a couple of them didn't make it Yeah. because I got some big ones. They're a couple of, like 24-inch long suckers. Wow. Those are worth hundreds of dollars. Yeah. Well, the one was extremely valuable, golden looking one, and unfortunately that one died. So Well, send me I a inher- picture. I inherited this.
I think,
When
let me just say, you don't have to stop this conversation, but I'm stopping the recording right now.
Yeah, I guess that's That's a a good good thing to idea. do. Yeah, Good night. We can pick it up later. Yeah, I'll see if I'll send you a picture or two so you can see what it looks like. Okay. Good night,
Well,
everybody.
Good night. Good night. Good
good
night.
night. Thank you very
Good
much.
job.
Good night.
Good night.